Good day, everybody. We are moving on to another topic on the palliative care lecture series today. This is advanced care planning. And a frequent misnomer is that people call it advanced care planning, and there's nothing advanced about it. This is basically something that you do in advance. You do something beforehand, which is why it is called advanced care planning. Now we will look at the objectives that we have. To understand the concept of advanced care planning and why it is important to be able to ponder the ethical and legal imperatives of advanced care planning, to have an idea about the areas that need to be covered in advanced care planning, and when should we resort to discuss these with the patients and their families. To understand the standards by which medical decisions are made in palliative care. So there are hierarchical standards by which the clinicians are supposed to arrive at decisions. So a little bit about that. And to know the means of advanced care planning available worldwide. Because this is something not formally available in Sri Lanka, we will look at other different means for advanced care planning available in the global context. To identify the problems and conflicts associated with advanced care planning. So it is not without problems, it has its own problems, conflicts, dilemmas that we have to face as we go. And given the Sri Lankan legal context, we might have to adopt certain things. And as for the time being, what form of a strategy could we have for our clinical settings? We will also discuss about that. I wish this session was an interactive one so that we can clarify ourselves, even come up with new ideas, but the ongoing pandemic restricts us from doing so. So the essence of palliative care, we will just brush through the definitions of palliative care. So the World Health Organization says this is an approach that improves the quality of life of patients and their families. So we are not just confining to the patient care, but we are also involving the family in the decision making, and we are also taking care of their welfare. So quality of life of patients and their families, failing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems which are physical, psychosocial, or spiritual. And palliative care is defined by the International Association for Hospice Palliative Care in slightly a different manner. This is a very recent definition, which goes on to say, palliative care is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. It aims to improve the quality of life of their families and their caregivers. So here, in addition to the families, the definition has also included the caregivers, the care for caregivers. So that includes us as well. So this is important when we think about advanced care planning. So a little bit about the background. So what is advanced care planning? It is a process that enables individuals to make plans about their future health care. So why is this needed? We will come to that. Or even, I will tell it right now. So in palliative care, we are dealing with patients who are diagnosed with life-limiting illnesses. And they tend to lose their mental abilities or the mental capacity to engage with their own decision making. So then, towards the latter part of the trajectory of the illness, the patient might not be able to participate in decision making, which is why we need to get their kinds of values, beliefs, preferences, wishes before they lose capacity. So we need to retrieve all these information from the patient. So that is the that is the key in palliative care, in advanced care planning. So we need to know what the patient's thought processes are. So then, looking at what mental capacity is, it is the ability of an individual to make informed healthcare decisions for self. So the patient, when the patient can make decisions for self, when the patient can participate in decision making alongside the clinicians, the patient is deemed to possess mental capacity. And when the patient is not able to do that, we say the patient has lost mental capacity. So how to assess mental capacity, we will come to that later. And so the mental capacity, so the clinical decisions that the patient is supposed to make can be about invasive forms of examination, physical examination, investigations, or even treatment. So, as we said earlier, the palliative care patients tend to, suffer a form of cognitive deterioration as their diseases progress and lead to diminished mental capacity. So, don't we assess the patient's mental capacity in our routine clinical practice? Oh, we do. So, for instance, if you are a nursing officer and you want to change the patient's bed sheet, you are taking care of the patient's hygiene. So, as the nursing officer, you are concerned about the patient's hygiene, and you ask the patient to sit up and even sit in a chair while you change the bed sheet. But then the patient's wound has just been dressed and it is intensely painful, and the patient says, no, nurse, I'm really sorry, I cannot move out of the bed, and my wound is really painful, and can we postpone it to tomorrow? And then it is a well-informed decision, and the patient completely understands the consequences of not changing the bed sheet, but her preference for the day is that I cannot move today. So then the nurse would agree, okay, then let's do it tomorrow. So this is a very basic form of mental capacity assessment. So you do that on a day-to-day basis. And how to determine mental capacity? So there are 4 criteria to determine whether or not a patient has mental capacity. So for you to say that the patient is capacitous or the patient has mental capacity, the patient must be able to understand the full extent of the information given to them. Right? You might tell about the kind of treatment that you are going to administer, what benefits it would have, and what would be the side effects, and all that. So the patient should be able to understand the full extent of the information given. And the patient's mind must be able to retain the information long enough to be able to make the decision. Some patients, as part of their disease process, can be forgetful. So then the patient might not be able to retain all the information that you have shared with them. So then the patient must be able to retain the information. Then the patient must be able to weigh between the pros and cons of going for the treatment. So weighing up the information available to make the decision. And finally, the patient must be able to communicate the decision to the healthcare provider. So that could be talking, using sign language, writing down, even simple muscle movements. For instance, with an ICU patient who is barely able to move the eyes, they can say no, or gesture with a slight nod, yes, yes. So all these movements, with all these movements, you would be able to understand what the patient is trying to communicate. So this is very important. So if all four of these criteria are met, the patient is deemed to possess mental capacity. So mental capacity is actually a legal concept. It is defined in the mental health legislation of Sri Lanka, and it is actually stemming from the Mental Capacity Act back in the British colonial era, but now the most revised form of the Mental Capacity Act in the UK was formulated in 2005. So what does the legal system prescribe us about advanced care planning, what they tell us about the patient's mental capacity? So the legislation asks us to follow 3 principles when we make a mental capacity assessment. So the first thing is that all adults, unless proven otherwise, are considered to possess mental capacity. So you have the burden of proof to say that the patient does not possess mental capacity is through assessing all those 4 criteria. But unless proven otherwise, all the adults are deemed to have mental capacity. So what is the age limit for you to be called an adult? In most legal systems, it is 16 years. In Sri Lankan context, we take 18 years for a person to be said capacitous adult, but even what the legal systems and clinical guidelines elsewhere in the world recommend is that even if the patient is a pediatric patient, 10 years old, if by the psychometric assessment you believe that the patient is able to understand what you're saying, able to retain it, able to process and communicate back to you about the decision, even you have to consider, you have to factor whatever the child is telling you about their preferences. You could not just neglect it. So they also have their ability to understand and process the information. And so the long-term conditions such as mental illness, dementia, learning disability, even there can be patients with Down syndrome with some degree of learning impairment living into their adult lives. So they can be patients who have impaired mental capacity, and when in doubt, you need to assess with those 4 criteria. And then there can also be temporary states of confusion, unconsciousness, and effects of the medications such as opioids, benzodiazepines, or even alcohol. So in such instances, the patient's mental capacity will be impaired in a certain point in time, but when they come off the effects of these drugs, they may recover their mental capacity. So you also have to be cautious about that. So mental capacity is not a one-off assessment and you label the patient to have lost mental capacity. It's not that. So dynamic versus static. So if it is a patient with IQ impairment from birth, it could be a static one, and in transient states of mental capacity impairment, it would be a dynamic one. Then the second principle is that you must be able to demonstrate that you have made every effort to encourage and support the patient to make the decision themselves. So you give the information, you make the necessary clarifications. The patient might have questions, so you make clarifications and support the patient to come into the decision. Some patients might also want to involve the family members, their next of kin, friends, in arriving at the decision. So you support in all these social manners as well. But you also have to respect that some patients would not want to engage their family members in decision making. So you also must respect that factor there. So thirdly, the decisions must be honored regardless whether they are considered to be detrimental from a medical point of view or your opinion. So as the clinician, you might wonder, I'm the person who is knowledgeable about the form of, what sort of a disease this is, what sort of a prognosis does it have, and what is the scope of treatment, and what are the chances of this treatment benefiting this person. So you might consider yourself to be the expert, but then if the patient says that the patient does not need one form of a treatment, although it contradicts with your medical opinion or the personal opinion, you must honor the patient's expectations. So here the same thing. Even if you think the decision made by the patient is eccentric or unwise, that doesn't mean that the patient lacks mental capacity. He might still be able to understand and could be making a well-considered, well-informed decision. And if you are in doubt, well, say you are a physician, you are a general practitioner, you are a nurse, and you are not really sure, especially in terms of a sinister decision, whether or not to attach a patient to a ventilator. You have had the discussion with the patient, and what the patient is saying is not very consistent, and you are not very clear whether the patient is understanding what you're saying. Then it is always safe for you to consult a clinical psychologist or a psychiatrist to do a proper assessment about the mental capacity. So on ethical grounds, as I said in a previous lecture, ethics is the cornerstone or the heartland of palliative care. So we have to base our decisions on ethical grounds, whether what something is right or wrong, but it is quite an arbitrary thing. So on ethical grounds, so the basic principles of ethics would be patient's autonomy, whether we are engaging the patients in the decisions, and are we honoring the patient's preferences and values. And then beneficence over non-maleficence. So we are aiming net benefit to the patient, and even there can be certain treatments that can be on the fence. It could prove benefit. It could be it could prove some harm to the patient. So you have to strike a balance and get the patient's opinion, and even get a senior clinician's opinion about your decision, and arrive at it. And then justice. You're not only doing justice to the patient, but you are also doing justice by the society where you are practicing medicine. Yes, I think we will come to that later on as well. And then there are Kantian ethics or deontological perspective, and the utilitarian or the consequentialist perspective of ethics, which we will discuss in another lecture. And now we will see when can we discuss um, the advanced care planning with the patients. So they have to have some understanding to start with um, before resorting on the discussion, because this could be a bit sensitive to some of them. So to be able for us to, identify the point along the patient's disease trajectory, where to start, these discussions, we better understand about various illness trajectories. So as we have discussed in the lecture on introducing palliative care, we are mostly dealing with three forms of disease trajectories. If you would look at the red line on the graph, so that is the cancer trajectory. So at this point where this is the starting point of where the patient is being diagnosed with the terminal illness, so being diagnosed with cancer, and there is a gradual decline in the patient's functional or health status, and beyond a certain point, having developed all the complications, metastasis, paraneoplastic syndromes, the patient's clinical status deteriorates suddenly over a course of days, patient leading to death. So that is the cancer trajectory, and it is more or less a predictable disease trajectory. So we usually have enough time to make all these decisions. But when it comes to organ failure, there is a gradual decline again in the patient's functional status, and this is the point where the patient is being diagnosed, and there is a progressive decline of the functional status with intermittent dips in between, where the patient suffers acute exacerbations or even acute on chronic renal failure and so on. So although the patient's functional status recovers to some extent after an exacerbation, it does not come back to the previous level. So it is a progressive decline again, and in each of these exacerbations, the patient might, the patient might die in each of these exacerbations. So these conditions are hardly predictable in terms of their prognosis. And the last trajectory given in green is the dementia and frailty trajectory, which is quite a fluctuating one with ups and downs. But to start with, the patient has a very poor functional status. So again, the prognosis is hardly predictable, but could be a bit better than organ failure, still worse than cancer. And so with this yellow arrow, you would see that early identification of the patient's deterioration is valuable when we diagnose life-limiting illnesses, and we need to start these discussions early before the patient loses mental capacity, beyond which point we would not be able to engage the patient in decision making, and we will not be able to value the patient's autonomy. So the palliative care continuum, this also we have discussed in the previous lecture. So there is, for instance, preventive care to start with, and then there is the point of diagnosing the life-limiting illness, and the curative and life-sustaining treatments, which is depicted by a green color, is starting fully blown curative care in the beginning, and it is tapering towards as the patient progresses towards death. And palliative care, we are starting small, and then we are paying more attention to palliative care than for curative care as the disease progresses. And this is the point where the patient dies, and beyond that, we are giving bereavement support to the patients. And what are the things that we need to discuss in this advanced care planning? So the first step would be to break bad news, because the patient might not even know, especially in our setting, that they have a life-limiting illness. So there is a fair bit of collusion where the clinicians and family members are reluctant to disclose the full extent of their diagnosis and prognostic information to the patient. So we might need to tell the patient that you are in such a situation. So we explore the current understanding about the terminal nature of the illness, the life-limiting nature of the illness. So what do you understand about your disease? And then we need to explore the need for information. Some patients in our culture might not even want to know about the full extent of their illness, or rather they will ask the family members to get involved with the discussions and even make decisions. So we need to explore the need for information. In other countries, they always, like mainly in the West, they consider the disease-related information to be an asset of the patient, and they always try to communicate this information to the patient, and based on the patient's consent, the patient's wishes only, these information can be transferred to the family members. And whatever the information we give, we need to cater to their requirement. They might want to know about the prognosis, how much time do I have to live, but they might not want to know the forms of treatment available, and they would want the family members to make those decisions. So we cater the information according to their needs. And then there might be a little bit of denial, and where the patient might be distressed, where you need to comfort, and the patient might burst into tears. So we could allow the patient to ventilate the feelings. So all of these are important when we communicate efficiently. And ensure understanding. So you can ask the patient to repeat back whatever you have said, so that you know the patient has understood. And then summarize. You can summarize yourself so that you know that you and the patient are on the same page about things, and offer further follow-up. So there are different models of breaking bad news, which we will discuss in another lecture in the palliative care series. So there is case 10-step model, or the spikes model, to for you to train yourself in breaking bad news. So we will discuss it in the other lecture. So, but it is important that the patient understands what form of disease he or she has, and a little bit of about the prognosis as well to start with. And why is advanced care planning needed? So the patient must also understand this. So you are likely to lose your ability to engage with decision making in the future, because there can be a little bit of, your ability to think might get worse towards the end of the disease. And then it is important that we document, or that we, have access to your preferences when certain decisions are to be made later in the course of the illness. So it is a way of extending mental capacity of the patient, extending patient autonomy beyond the point that the patient loses mental capacity. What to expect in the disease trajectory? So, according to the natural history of this disease, the clinicians might know at this point the patient is likely to lose mental capacity when the patient has brain metastasis, or when there is this metabolic derangement, which is quite likely in the coming weeks. So you anticipate that and decide with whom the patient would want to make the decisions. Would you want to involve the family members, or you do not want to involve them? What are the options available, pros and cons of each? Can I revise my statements or preferences as circumstances change? Yes, yes. Of course, the patient can revise it. So, and the limitations would be the patient can refuse treatment that are inappropriate, but the patient cannot request for therapies that are clinically deemed inappropriate. So the legal and health system limitations are there, so the patient must be able to understand what to expect and what are the limitations of our system. So what are the legal limitations? In our context, in the Sri Lankan context, we cannot really forego on life-sustaining treatment. We cannot withdraw a patient on a ventilator unless there is brain stem death. So because that leads to the patient's death. Although it is clinically deemed futile, you cannot do that legally. But the physicians have found ways around it, how to do certain things in best interests of the patient while also, doing social justice. And again, not administering a certain life-sustaining treatment, for instance, again, a ventilator to a patient who is, unable to breathe at the terminal phase would also amount to from a legal point of view, a crime, because there is an act of omission that leads to the patient's death. You are not doing something that could have prevented the patient's death. So that, again, is illegal in our system. And the clinical system limitations are that although the patient has not specifically refused some form of life-sustaining treatment, and on clinical grounds, you also wonder whether the patient could benefit from this form of treatment. So then you are on the fence. The patient is, not refusing it, but the clinical system you are located is such that you cannot really administer this form of life-sustaining treatment to the patient because resources are not available. So those are some. And what factors do we need to consider when we document the patient's preferences in advanced care planning? So the Maslow's hierarchy of needs, this is something that is also taught in management and marketing, but it is also very important for medicine. So the patients have different forms of needs. So the very basic needs are the biological and physiological needs: food, sleep, and water. And then safety, security, health, and finances. Moving up in the pyramid, we have love and belonging, friendship, intimacy, family connections, and then self-esteem. The patients need to be respected. They have to maintain their status. They have to have some form of recognition, strength, and self-esteem. And the final, or the most highest end of the Maslow's hierarchy of needs is self-actualization, where the patient is meeting one's full potential in life. So that is different for every person. But it is important that we have an idea about this pyramid. So to start with, we have to ensure that the patient has the basic biological and physiological needs, and then prioritizing the other aspects of care that are staggered up on the pyramid. So the basic needs and psychological needs, and finally the self-fulfillment needs. But is this hierarchical level really apply to all patients at all times? Well, have you considered this? Some patients might have certain self-esteem needs, which is level 4 according to this pyramid. Self-esteem needs. I can endure physical pain to some extent. So the patient is neglecting on the basic physiological needs, right at the bottom of the pyramid. Be free from physical pain to have that basic comfort is a basic physiological need. But the patient has decided to sacrifice pain, sacrificed the right to be free from pain to establish some self-esteem for him or herself. So there, the pyramid is not really upright, it's upside down. The patient has made a well-informed decision. So we also have to be sensitive to all these nuances in decision making. So as the patient loses mental capacity, how to make the decision? So there we need to learn about 3 standards of decision making. There is a hierarchical order, and in clinical decision making we almost always follow this order. We are bound to follow this order. So there is subjective standard, which says that, so we will come to that later, subjective standard, substituted judgment standard, and best interests standard. So through the subjective standard is to decide based on the patient's previously explicitly expressed wishes. So the patient has now lost mental capacity, but you have access to the patient's preferences through previous documentations or whatsoever, and then you have at least a note made on the BHT about them, and then we are basing our clinical decisions on what the patient has explicitly expressed. So that is the subjective standard. And then there is substituted judgment standard that strives to decide vicariously to resemble the decisions the patient would have made if they were competent, disregarding the decision maker's personal agendas and opinions. So this is involving a second person to substitute the patient in decision making. When the patient cannot engage in decision making, we involve a person who is known to the patient and who knows the in and outs about the patient in decision making. So we will come to that. We will elaborate on this further as we go. And then the best interest standard, when you do not have access to what the patient has expressed through subjective standard, and you do not have a surrogate or a substitute decision maker, then on clinical grounds and your expertise as a clinician, you arrive at the decision aiming best interests to the patient. So this is the third standard. It is the determination of the most favorable care choice over the alternative options available that would best enhance the patient's overall well-being. So it is always has to follow this order once again. So advanced care planning is aiming to secure the subjective standard and the substituted judgment standard. And when considering the best interests of the patient as a clinician, you also use your clinical acumen, but also you are getting the help of advanced care planning to make the best interests decisions. So what are the means of advanced care planning? So one is advanced care directives. Some people call them advanced directives or living wills. Secondly, you have advanced statement of wishes, beliefs, values and preferences. And thirdly, thirdly is the appointment of a surrogate decision maker through a legal documentation called lasting power of attorney. So advanced care directives. So this is a legally binding document that you document with the patient. So the patient can refuse certain treatment modalities through writing down a document, and there is a lawyer involved in the decision making, and if the patient wants, the patient can also involve the family members in documenting these documents, documenting these papers. So advanced care directives, or advanced, these are also called advanced decisions to refuse treatments. So they can refuse treatment of any kind, including clinical, artificial hydration and nutrition, or any forms of life-sustaining treatment, cardiopulmonary resuscitation, circulatory support mechanisms, even external cardioverter defibrillators, renal replacement therapy, which is dialysis, antibiotics, transfusion of blood products, artificial ventilation, and so on. There are limitations of advanced care directives. They cannot make a legally binding request for treatment that are clinically deemed futile. So the patient cannot demand for that. The patient cannot refuse basic care. So certain patients who are clinically depressed might refuse shelter, warmth, and hygiene. So they cannot ask for that sort of things. And then patient cannot, in most legislatures, including Sri Lanka, the patient cannot refuse that their lives be ended. So then we will look at how we can decide the advanced decisions to refuse treatment, or advanced directives, are valid. How do you decide the validity of these documentations? When are they valid, and when are they invalid? So it is valid if the patient had mental capacity at the point of composing it, and it was made voluntarily by the patient, and there was no suspicion that the patient was coerced or pressurized into making those decisions. And the patient must have been informed about the nature and the purpose of treatment that they are refusing. So in those circumstances, advanced directives are valid, and there are further elements. So it is also applicable if there is a refusal for a specific form of treatment. The patient might refuse cardiopulmonary resuscitation, but the patient might not refuse artificial ventilation, hydration, and nutrition. So the refusal of treatment must be specific. And treatment in question is that specified by the advanced decision to refuse treatment. So now you are deciding on the specific treatment that the patient has refused. So, for instance, you are now about to decide on starting artificial nutrition on the patient, but the patient has only refused CPR. Then, based on the patient's refusal of CPR, you cannot decide to not administer clinical nutrition. So it is your call to make. So that is one important aspect of advanced directives. And circumstances that existed at the time of composing the advanced directive must prevail at the time of decision making. So if the circumstances have changed from the from the time that the documentation has been made, then the advanced directives might not be valid. So we will come to that, how that can affect advanced directives. So changing in circumstances is that at the point of documentation, there was no scope for cure, there was no, medications to treat this patient's condition. But now, at the time of making the decision, there is a new drug that has shown promise to cure the disease. Then the circumstances have changed. So if the patient were capacitous at this point in time, he would have decided differently. So you have to consider that in making the decision. So the person has done something clearly inconsistent with the advance directive statement. So the patient has refused, cardiopulmonary resuscitation, but the patient's nonverbal expressions say that the patient would want certain treatments to be started on him when the patient is actually in a cardiac arrest. So, or even patient has communicated, albeit vaguely, about a change of preferences with the nursing officers later on. So that is important to know. And if the patient had at a later point withdrawn the decision, withdrawn the advance directive in verbally or verbally or in writing, then the advance directive is not valid. And if the patient has also conferred the power of decision making to a surrogate, then again the advance directive might not, whatever stated in the advance directive might not be valid. So the limitations, even in the developed parts of the world where advance directives are in place, is that there is widespread use of advance directives in the UK and the USA. So in the UK, the national legal clinical frameworks have incorporated advanced care planning into them, but research is underway to ascertain the effectiveness of advanced care planning. And on the other hand, countries like France that place more emphasis on social justice against individualism or individual autonomy, question the validity of advanced directives. So their argument is that we are placing, an undue form of emphasis on individual autonomy. So we are trying to respect individual autonomy by all means through advanced documentations. And sometimes there we might be jeopardizing the rights, wishes of the family members and the wider society, because we are using some intense resources such as ventilators to sustain the life of patients when that decision is clinically deemed futile. So the ventilator on clinical grounds is not going to work on the patient, but still you are administering it. So that might strip the right of another person, another patient with better chances for cure, who is deprived of the ventilator. So that is doing some social injustice. So there is a counter argument for the use of advanced care directives. And advanced documentations in the USA, the elderly population is said to have documented their advanced wishes, so the prevalence is about 35%, and those with a terminal illness, it's about 70%. So that is the kind of highest documentation rates that is reported from a country. All other countries are behind. And developing parts of the world, so advanced care planning is not well established, not well developed. In some of the countries, such as Sri Lanka, at the moment, is not the legal system is not backing, the foregoing of life-sustaining treatments and so on. And the fluctuating circumstances, the clinical circumstances of the patient might also pose questions about the advanced directives, the validity of them. And then the advanced directives that we discussed just before are legally binding documentations. And what about the informal documentations that you make on the patient's clinical notes? They are non-legally binding. You can write down the patient's wishes, beliefs, values, preferences in the clinical notes, so that you can make use of these documentations later on in decision making when the patient loses mental capacity. So this could be a strategy for the moment in the Sri Lankan context. And thirdly, the third manner of advanced care planning would be the appointment of a surrogate decision maker. You do this through a document called the lasting power of attorney. So lasting power of attorneys are two kinds in the context of UK. So you have lasting power of attorney for personal welfare, where the clinical decisions are concerned. And on the other hand, there can be a legal appointment of a surrogate for decision making about personal matters, legal matters, property, and all that. So we are mostly concerned here about the lasting power of attorney for personal welfare, where a surrogate decision maker or a substitute decision maker is being appointed, usually legally, to decide on behalf of the patient. So that person better be familiar with the patient's preferences and beliefs. So there are 5 types of surrogates. Ideally, the surrogate decision maker is appointed by the patients themselves, because the patient knows who knows about them the best. So it is important to get the patient's idea, ideally, about who this ideal surrogate decision maker should be. But then there are 5 other forms of surrogates. So through the advanced care directive, the patient can legally appoint a surrogate decision maker. Or then the patient can informally designate a person during the ward rounds or clinical encounters. Okay, doctor, please, if I lose my capacity, you can ask my son to make decisions on my behalf. And there are court-appointed surrogates when things are in conflict, especially when the clinicians are in conflict with the family members, and when different family members are in conflict with each other, they have starkly different opinions, then the court might make a well-considered decision to appoint a surrogate to decide on behalf of the patient. And then there are default surrogates. So this is very common in the Sri Lankan context, where the clinician decides, okay, so this is the patient's daughter who is visiting the patient more frequently, so she better be the default surrogate. And then there are special surrogates for unbefriended patients. So for the patients who do not have friends or relatives, there can be appointment of special surrogates, usually by courts of law. We will discuss about that later on. And then substituted judgments made by these surrogate decision makers are regarded to be of extreme value by the ethicists and even the legal systems within a country. That is because in 68% of the instances, these proxy decision makers make accurate decisions to reflect their patients, their loved ones' preferences. So their accuracy of decision making is very high. 68% is not that high, but that is high when compared to the clinicians who are engaged in decision making. So in all the studies, it has been shown that the clinicians make inaccurate decisions than the proxy or surrogate decision makers. Right. So then we talked about the advanced care planning that aims to secure the subjective standard and substituted judgment standard. And thirdly, we will look at what best interest standard is. So the best interests is interpreted differently by different clinicians. Although you have the same clinical background, even there can be conflicts between nurses and doctors, and there can be conflicts between doctors and doctors, nurses and nurses, because you are ultimately subjective human beings who analyze the clinical best interests and patient best interests in conflicting ways, in contradicting ways. So essentially, you may have conflicts in between yourselves. So the best interest decisions is not a straightforward thing. So you can be aided by the advanced care directives, and you can involve the surrogates in decision making, but then the clinical best interest decisions you have to make is not without doubts. But ultimately, you aim to achieve best interests to the patient. And the decisions must also be least restrictive for the patient's future choices. For instance, you decide on, this is just an example, it's not about really a life-sustaining treatment, but amputation, then the patient cannot reverse the decision if the patient regains mental capacity. So the patient's future, the decisions must have least implications, least consequences on the patient's future choices. So this is something that, as clinicians, we have to bake in within ourselves. Yes, we are clinicians and we are experts in our fields, but that does not necessarily justify our competence in social concerns and values of the patient. So the White et al., the paper argues that clinicians must not form the sole authority over substituted decision-making, even with regards to unbefriended or unrepresented patients, and instead propose the patients to assume an adversary role. So physicians sometimes assume a paternalistic role in decision-making. So I am in charge of the decision and nobody else can influence me. But on the contrary, the nurses who spend many hours with the patients might have a better understanding about their wishes and preferences. So you need to get their input. And it is also important you have interdisciplinary team meetings also involving clinical ethicists as deemed appropriate, so that you make a well-informed decision. So you aim the clinical best interests, but then what about the patient's best interests that the patient himself or herself defines? So when in dispute, it is always important that you seek ethical guidance from an ethics committee, a clinical ethicist, or legal opinion from courts of law. So unbefriended patients, there is a different form of, there's a legal appointment of a form of surrogates for the patients who do not have next of kin, who do not have relatives, hence are unrepresented. So the courts appoint an independent mental capacity advocate who would go into the background of the patient and try to assess the patient's history as far as possible and give opinions about the patient's background to the court so that they can arrive at good, better decisions. So they can also provide written reports to the healthcare provider or even the courts of law. So this is a person who is not known to the patient to start with, and then they get to learn about the patient, and from an independent perspective, they are looking at the patient's background. So there are problems with advanced care planning and there are plausible solutions. So what hampers the ability to engage with advanced care planning? So the healthcare providers are inexperienced in discussing about death and dying. They're afraid to discuss and not knowing what to expect, what would be the emotional reactions of the patients. So they are afraid, and they are also worried about the legal implications of making these decisions, especially in contexts such as Sri Lanka. And then there are prognostication problems. I will not go into depths there, but there are simpler ways of prognosticating other than sticking to the objective tools that are aimed at prognosticating. So we cannot say like when the patient will die and when what is the life expectation, the survival. Not knowing that, it is hard to plan ahead. Lack of legal frameworks, as I said. And so you also have to look at the advanced directive as a modifiable document. So as you go, it is revised regularly in light of shifting clinical and psychosocial dimensions of the patient. The patient might decide otherwise later on in the course. So you have to keep revising the document as per the patient's preferences. And there can be also changing perspectives of the families, their values, beliefs, and expectations. And also the legal system might change. There can be new additional, treatment modalities available with the elapse of time. So you always revise the document. And because palliative care is aiming to improve the quality of life of family members as well, you have to ensure that the family members are also cared for and they are in better hands, because it has been shown that especially when deciding for patients in critical care settings, intensive care settings, when the family members were involved about life-sustaining treatment decisions, about 82% of these surrogates have succumbed to post-traumatic stress disorder. So they have these decisions have health implications on surrogate decision makers. So you have to take care of them, and the decisions have to be fair by them as well. And the patients might also be concerned about the effects of decisions on their loved ones. So if the patient had not refused to have artificial hydration and nutrition, the patient might have a protracted course of dying, a protracted course of suffering as well. And so a patient who is suffering might also bring on suffering to the family members. So the patients and as the healthcare provider, you might also be concerned about this. So it is a delicate balance between the well-being of the patient and that of the loved ones. So to communicate is the key in resolving these disputes. So in seek of a strategy for Sri Lanka, depending on the context that we have at the moment. So discuss early with the patients. Cater the information that they need to know, but give the information to the patient. Give them the benefit of doubt of knowing the full extent of their illness. And write a statement of wishes, preferences, and values, and get it signed by the patient in maybe the clinical records. And individualize the care provided as per the patient's wishes, not too less, not too much, and also safeguard yourself from legal implications as much as possible. And revise as necessary and in a regular manner. Evaluate the process, discuss the emerging problems in the interdisciplinary team meetings, and devise sustainable institutional protocols. So not only institutional protocols, you also have to have national policies about advanced care planning, because the clinical aspects, the ethics, and the legal opinion of these decisions have to be on the same page. They must not be conflicting with each other for you to form clinical guidelines, comprehensive guidelines or frameworks in decision making. So there has to be non-contradicting ethical, clinical, and legal views, which is why you also need to involve clinical ethicists and legal officers in devising these frameworks. And it is essential that you as clinicians take care of each other. If a doctor is, feeling distressed, a physiotherapist might, notice that and, talk to that doctor. So you have to have your backs, like help each other, discuss among yourselves the kind of distress you are going through, and it will, you will normalize the feelings, justify the feelings, and help each other. And the imperatives are: do not assume what the patient might like. Ask and clarify. Pay attention to the cues. The patient might not, while the patient is saying something verbally, the patient's vocal expressions and person's non-verbal expressions might be saying something else, that the patient is making this decision out of pressure. So pay attention to the cues. And be non-judgmental. If the patient is not refusing something that you, in a clinical opinion, think that the patient should be refusing, don't be judgmental about it, because you have given the choice to the patient. Then, so what aspects could a statement of wishes and preferences carry? So when we document, what do we incorporate in a statement of wishes and preferences? So the patient can state, I prefer to be cared for by these people, and this person would make decisions on my behalf when I'm not able to. I wish to be cared for at home whenever possible. I do not like to have tubes in my throat to assist breathing, but mask-administered forms of ventilation are fine. I prefer not to have narcotic painkillers or drugs that may make me overtly drowsy. I wish to stay as alert and awake as possible. Some degree of pain is acceptable by me, over the preference to retain wakefulness and consciousness. Please do not allow these visitors or anyone who would make trouble to my family. So the patient can be clear about these. And then last wishes and testimonies. And please, in the terminal phase, do not invite religious priests when death draws closer. The patient might decide otherwise. It's absolutely all right. And rather play some chanting of Pirit, for instance, in low volume through a cassette player. So the place of death, what's your preference? Place to be cared for and the place to die. So my funerary arrangements are to be made in this manner. So even if you have an electronic health record, electronic medical record, that would be of help to timely revise these preferences. And this is actually a misnomer. People sometimes use this abbreviation DNR to denote do not resuscitate. And it is actually a derogatory term, in my opinion, because you are not, you're not resuscitating the patient by all means. So the ideal term would be DNA CPR. That's an example. Do not attempt cardiopulmonary resuscitation, DNA CPR. So you are specifying what aspect of resuscitation are you foregoing on, but you may still give clinically assisted hydration. So you are doing nutritional resuscitation, you are doing hydration resuscitation. So do not resuscitate does not really mean anything. You have to be specific about the forms of life-sustaining treatment that you are foregoing. So in essence, advanced care planning has some potential to extend a terminally ill patient's decisional autonomy beyond the likely loss of mental capacity in the future. Early advanced care planning discussions regarding the patient's health and welfare needs in anticipation of cognitive deterioration is essential. Three main means to accomplish advanced care planning and the three standards to decide. We have discussed this, and it is very important that you have a clear understanding about these at the postgraduate level. The whole spectrum of needs to be prioritized in line with the patient's expectations. So we talked about the Maslow's hierarchy of needs and how even the pyramid can turn upside down. And to revise the advanced care planning documentation in a regular manner is very important as well. And there is a wealth of reference material. I have actually gone through each of these to compile this presentation. But again, I would suggest you to read the Introducing Palliative Care, the book, a very simple book by Professor Robert Twycross to further your knowledge about these aspects. And it's a booklet, it's a very small book, and it is very comprehensive, succinct. So any questions, you may email me through my official email ID, or you can post any questions in the Palliative Care Google Classroom module. Thank you.